Good afternoon or good morning, wherever you might be joining from. Thank you for joining today's session in LHSN's Safer Care Accelerator webinar series. My name is Dee Dee Thompson, and I'm a policy fellow here at Imperial College's Institute for Global Health Innovation, and I lead on the LHSN program. We're thrilled today to be joined by Dr. Peter Pronovost, who will be discussing how to design governance, quality management structures, technology systems, and a leadership culture that eliminate harm across an entire system. And while Peter requires no introduction, given his eminence in the world of patient safety, I'll go through a very brief introduction before handing it over to him. So Peter is the director of the Armstrong Institute for Patient Safety and Quality at Johns Hopkins, as well as Johns Hopkins Medicine's Senior Vice President for Patient Safety and Quality. As one of the world's leading authorities on patient safety, Peter has developed a scientifically proven method for reducing central line infections, which has reduced these infections at the national level in the U.S. by 80%, saving thousands of lives and hundreds of millions of dollars annually. So now, without further ado, I will go ahead and hand it over to Peter.
Dee Dee, thank you, and thank the entire Lhsn Imperial team, and most importantly, thank all of you from the far reaches of the globe for joining us today. I know it's quite early in the morning for some of you who are joined on, and we appreciate your commitment to this topic, and we certainly hope we will make it worthwhile for you. You know, I'd like you to write the words "I will" down at your desks. I will. You see, the reason we're doing this isn't just to share knowledge. It's so you will do something when you come off this or go back to your job or wake up the next morning. Because right now, across the globe, the best estimates we have suggest that preventable harm is the third leading cause of death. Sadly, and admittedly, we don't have the best measurement systems to know exactly, but we're fairly confident it's in that range. And though medicine today does miracles, medicine today still leaves somewhere between 1 in 3 and 1 in 4 patients leaving their healthcare interaction saying, "I wasn't respected. I wasn't listened to. I don't know what to do when I leave." And medicine today squanders about a third of every dollar that is spent on therapies that aren't helpful, that don't get patients well. Some of you may have seen several months ago the civil unrest in my city, Baltimore. What you didn't see, though, was that the median net worth of those people that were uprising is about $10,000. When you look at what the U.S. wastes on healthcare, on those therapies that don't get patients well, that's also equal to $10,000 per family or per household in the U.S. So what we're seeing is that getting this healthcare quality right is key to healthcare, but it's also vital to our global security, our global economic development, and we are the only ones who are going to do it. There's enormous examples that pay for quality, though it may influence the quantity of care consumed, has very limited potency in looking at the quality of care that we provide. And what does impact quality is the things that you and I do every day. But to change that, we're going to need to change our story. Some of the researchers may call it changing our mental model. You see, stories are one of the most powerful forces for change. They either pin us to our current performance or they propel us to new pinnacles. You change the story and you change everything. Stories like, in the U.S. context, John F. Kennedy saying, "I want a man on the moon," and we achieved that. Or Martin Luther King, a dream of nonviolent protest. Or Ronald Reagan, tear down that wall. Bold new stories that led us in a new direction. And when I think about what's holding us back in healthcare, globally, I believe we're telling some dysfunctional stories to ourselves. We're telling stories that quality is still focused on physicians rather than on patients. And there's many examples of that. We still see quality as a project rather than as a performance system. That is, I work on my CLABSI or CLAUDI, but I haven't put it all together in what some might call a high reliability organizing or mindful organizing, or into a performance system. You'll see our efforts today to do that. Too often we work to change quality through coercion, whether that's economic incentives or management mandates, rather than through inspiration and intrinsic motivation. And we know that intrinsic motivation is much more powerful than extrinsic and coercion, but it's not the norm in healthcare. We haven't produced those kinds of leaders yet. And too often we see quality is based on the heroism of our clinicians rather than the design of safe systems. So the net effect of this is, though we seek to be highly reliable organizations, or which equals that we're learning organizations, many of the stories that we tell hinder us from doing so. Now, I'd like to share with you the story of Johns Hopkins Medicine to begin to evolve a performance management system. It's a humble story that began and continues with personal shortcomings on myself and my organization, but I hope it's a hopeful story that at least we're seeing glimmers of hope of how to reorganize and evolve from a safety as a project to safety as a performance system. You see, on a snowy night in February 2001, just shortly after the Institute of Medicine released to Human, this adorable little girl, Josie King, who looked hauntingly like my daughter, died needlessly in her mother's arms. She was taken off of life support. She had been burned, but the clinician saved her. But a central line infection sacrificed her and started a cascade of unrecognized sepsis. Her mother, Sorrel, an amazing woman, came to the hospital on the year anniversary of her daughter's death and sat down and looked me in the eye and said, "Peter, could you tell me things are better now than they were a year ago?" She was worried that her other children may be harmed from care and that other patients might be harmed. And I looked at her and I wanted to tell her all the stuff we're doing. I wanted to give her the rah-rah speech. Yes, we're committed to safety. But in my heart, I couldn't, because I knew we weren't any safer. Our rates of infections were sky high. And indeed, the first root cause analysis of this little girl's death didn't even pick up that she died of a CLABSI, in part because they were so common at the time. Our story, we told ourselves, is they're not preventable. So we didn't even focus on it. So I looked at her and said, "Sorrel, I can't tell you Josie's less likely to die now, but we should be able to, and we will. We'll work to give you an answer." And so we packaged a program that involved a checklist. It involved culture change with the CUS program. It involved measurement and feedback, and fairly quickly and sustained now reduced these infections across our health system at Johns Hopkins, but importantly, across the U.S., working state by state, collaborating, learning, and now these infections we just recently published are down over 80% across all of the U.S. I know our colleagues in Abu Dhabi have done similar results. Our colleagues in Spain with the same program, in Pakistan and Peru, all similar results. The UK had a significant effort. I think the story is a little more complicated because of the measurement systems. But what we learned in this is that large-scale change is absolutely possible. So we got curious to say, well, what led to this? Because this is one of the few examples that we can say we really licked a global harm. And so we went into hospitals that were very low on infections, some a year or two, and some that didn't, and said, what could we learn? And what we found was there really wasn't the magic of a checklist, though the media would like us to believe that. Checklists were key, and they were important, but what we found is there had to be a very systematic approach from board to bedside to get low. We walked in, and that was the leaders had to declare and communicate a goal of 0 infections, very publicly. They had to create what we called an enabling infrastructure to make sure people had the resources, the skills, and the time and the data to do this work. They had to engage frontline clinicians and connect them in learning communities that we call, or my colleague Mary Dixon Woods from the University of Leicester calls, clinical communities. And they had to transparently report and create accountability systems. And if they did those things, their rates went extremely low. And we felt pretty good about this success until I met the mother of this little girl, the mother Lenore Alexander, heard us talking about or writing about these CLABSIs and came up to me with tears in her eyes and said, "Peter, why is it fair that you could tell Sorrel King her daughter's less likely to die, and my daughter died around the same time Josie did and is just as likely to die today?" This little girl died after elective orthopedic surgery from narcotic infusion while we have monitors that count your breath, and we know respiratory depression is a known side effect. Again, no other industry would tolerate that sloppy engineering, but we do, and we continue to do in healthcare, and girls like this continue to die. So I left this little girl's mother's interaction extremely troubled. And as you could probably tell, nothing could humble you more than to look in the eyes of a mother who lost a child needlessly. And I walked back to our team that has some engineers and said, we're thinking about this wrong. We're going about this one project at a time. And one of the engineers from the Applied Physics Lab, who happened to be working on the Pluto mission that you may have seen, said, "Peter, you're absolutely right. Healthcare has this backwards." And we said, how many harms could a patient in the hospital or a patient with chronic disease suffer? And you know as well as I do, I mean, that number could be 10 or 15. And he said, well, if we were putting a satellite up and it can blow up for 10 or 15 reasons, and it didn't blow up for reason one, call that reason CLABSI, but it still blew up, do you think we'd pat ourselves on the back and say, good job, it blew up, but that CLABSI didn't get us? You guys got to start thinking of designing a system that eliminates all harms. So we went some to the literature, some are reflections, some to many of you on the phone for colleagues to reach out and said, what would it take to move an organization where safety is a project to where safety is a performance system, or you might call it an operating system? And we said, well, we need to be laserly guided by a purpose. Everyone in the organization needs to know their purpose and focused on it. And healthcare hasn't declared a purpose yet. We need to be governed by some principles of how we'll treat each other, principles that are rooted in high reliability and just culture. We need a governance system, a leadership system, a management system, and a technology backbone. And so we worked to create this. We asked about 200 people, what's the purpose of healthcare? And perhaps not surprisingly, we got 200 answers. So we took the bold step of saying we will draft a purpose statement. The purpose of healthcare is to help people thrive, to prevent disease when possible, to cure when we can't prevent, to care when we can't cure, and all along to humbly and empathically and respectfully partner with patients and their loved ones to end preventable harm, to continuously improve patient outcomes and experience, and to eliminate waste in healthcare. Those of you who are hospital-based, the bold part of the statement is where we really live, but as a health system, we need to be moving our measures and our thinking about thriving, about preventing, about curing when possible. We also said, what principles need to govern behavior? Because perhaps your organization, like mine, has a great mission or value statement. Unfortunately, I would suspect most of your employees don't know it, and they probably don't live it. And so we said, what do we know about how we have to behave if we really want to lick harm? And the behaviors might surprise you. There's an internal one that I am humble and curious. Because without those two attributes, and again, I won't bore you with the support in the literature, you will not make progress, right? Improvement begins with humility and curiosity. Second, an interpersonal one, that we have to respect, appreciate, and help others. And every one of those is important. I could respect you, but if it's in my head and you don't know it, it doesn't do any good. And I could say I appreciate you, but when you're struggling and you need help doing work, if I don't roll up my sleeves and work alongside you, it's for naught. So all of these are important. And finally, we need to be accountable. And healthcare has grossly underdeveloped accountability systems, accountable to continuously improve ourselves, our organizations, and our communities. We needed a governance system, and we used a very simple metaphor that I would encourage you to try because it is profoundly powerful. What we said is that the board quality committee ought to function with the same discipline and rigor as the board finance committee. What do I mean by that? Well, our organizations, like many of yours, is quite complex and growing complex, more complex by the day, because we're buying ambulatory practices or ambulatory surgery centers or partnering with home care companies. And yet, we have a consolidated financial statement. Our board has line of sight oversight for every dollar that's spent and comes into our organization, and it funnels up into one performance statement. We asked, could we say the same thing about the oversight for quality and safety? And when we started, the answer was, are you delusional? We're not even close to thinking of that. So we had to organize our delivery system into some buckets, and we organized it into the inpatient hospitals, healthcare, which is our managed care company, international, which we manage a number of hospitals, ambulatory surgery centers, ambulatory practices, home care, and our child care services. Now, in each of these, we may have many companies or delivery systems. For example, when we started, we had 8 ambulatory surgery centers, and they never met. There was no common dashboard. They never shared learning. So we assigned each of these a chief quality officer, and their task was to create a table where anywhere care is delivered under your domain, someone has a voice in sharing goals, in agreeing on measures, in creating peer learning, and most importantly, in accountability. Now, it took us a while to organize this, and there's, some of these practices are owned by different groups, but now we have each of them have the tables. The ambulatory practices, we have about 70 of them, so they had to grow into regions. And we use this metaphor of a fractal, or you can think of like a fern cascading layers, where every higher level needed to create a table to connect lower levels to support peer learning, but also vertical accountability. But we may need to add more layers, so our ambulatory practice are grouped into regions or different clusters of practices, and then within that, those regions have networks where every practice is represented to share learning. We also use this model of shared leadership accountability, and this is absolutely key. You see, when we talk to those clinicians in the CLABSI effort to say, what really drove the change? I mentioned those 4 attributes, but what was even on a deeper level was that they told a new story. You see, when we started, they, like I began, saying these infections are inevitable and I have no power to do anything about it. I didn't see I had responsibility, I didn't see I can contribute, and I didn't see I had control. And when you provide those things, you change a news story. And so we dug further and said, well, what leads us to change that news story? And what we found is it's 2 simple things. That somebody, a leader, believes in those clinicians that they can do this. Yes, there's this inspirational component, and then they in turn believe in themselves. And 2, they create structures where they belong. They support them and connect them in peer learning. We call those clinical communities. But the accountability piece is this: leaders in practicing shared lead accountability have to make sure at every level people have the responsibility, they know the goals, they know their roles, they have the time and resources, and they have the skills to do this. As you know, there's a huge skill gap or training gap in quality. Most of us weren't trained in these things. So how we practice this is every layer, as we cascade this shared accountability, the higher level before they ever dream of holding someone else accountable, first looks at themselves in the mirror and asks, have I been clear about the goals and the person below me, their role? Have I provided them with sufficient resources to be successful? Do they have the skills and the time to do that? And then if that is the case, yes, then I can go to the next level and say, okay, what are we doing about this particular problem? And it cascades down. But we all are aligned in this shared leadership accountability. And if you can't name, literally from board to bedside, who these people are for every type of harm you're working on, you will not have an accountability system. But we needed a management system because this work is incredibly complex, and we've lumped it all together for the most part. But as the numbers of performance measures that have increased, we need some way to organize that. So, for example, in our health system in the U.S., I'm responsible for reporting over 1,100 different external measures. Yes, 1,100. Our home care companies have different measures, our practices, our surgery centers, just our hospitals report over 250. How on earth could I take that and make meaning of it to board members or senior leaders? In addition, when I ask our frontline clinicians, what are you most worried about? Most often, none of those external measures make the list. They're worried about internal things like handoff or workload. And so we needed a way to measure that. So we organized our work in this domain into 6 spheres. That is patient safety, which is our internal risks, performance on external measures, value, which is our efforts to reduce cost and keep quality constant or improve it, patient experience, equity and diversity, that is, are we providing the same care for every type of subgroup of patients you want to look at, whether that's by race, ethnicity, language, sexual orientation, religion, where are we going with that, and then population health. Now here's an example of how we organize our work and how we report up to the board. Here's just 4 of our domains because it gets too confusing. We organize our work across our system into these pillars. Patient safety, that we group into risky providers, and I know our Tim McDonald from CIDRA has done a lot of work in that with us. Risky units, that is, are we proactively identifying vulnerable units? In this case, there's good data from some of our UK colleagues that units that score low on engagement, on patient satisfaction, and on safety culture have much higher mortality and cost. But we haven't triangulated those data and proactively identified those units and supported them. So we do that. And then finally, risky systems, which is our error reporting, sentinel events, morbidity mortality conferences in there. We work at external measures. Those are all the things that we report externally, and we have a very clear charge from our board to be national leaders in anything we report, whether that's our home care measures, our hospital measures, patient experience. We have surveys in this country to do that, as well as narrative from grievances and compliments. And then finally, value, where we're implementing best practices and creating clinical communities. I'll get more to them in a second. Now, in each of these pillars, let me share with you how we do this. These cascade across our system. So the hospitals use these, the home care companies use these, the ambulatory practices use these. The measures vary, but by using these domains, it allows us to cascade up reporting systems. And we report using a tool from finance called the Management Discussion and Analysis. It's frankly nothing more than a shorthand for saying we provide quantitative and qualitative data. So we start at the lowest level at a unit or at a division in a department or a department, and they create this management and discussion where they report. It's a one-page summary on each of these domains where they're falling short with data, but then they are allowed to write context about it, about why that might be. Either the measurements are concerned, they're focusing on something else, they don't have enough time or resources, whatever the issue is, that their interpretation of what they're doing about it and why. And it's a great way for us to cascade up, allow variation and independence in what's important for home care versus an ambulatory surgery center, and yet have a way of aligning and communicating as an organization. And on all of our projects, those gray boxes, what you'll see are those same things that allowed a hospital to get 0. We say whether you're a department or a division or an ambulatory surgery center or all of Johns Hopkins Medicine, if you want to move the needle on everything, you need to make sure you declare your goal, you build an enabling infrastructure. That means you provide project management support, analytics, improvement science support. You engage clinicians and you connect them in communities, and you report transparently and you create accountability, right? And no doubt this will evolve, and it has evolved, but it allows us now to align and organize a very complex topic in a very complex system in a way that's meaningful. But I want to dive into that last box, value, of what we're doing for clinical communities. You see, again, with my colleague, the sociologist Mary Dixon Woods, when we partnered with them to look into explaining this reduction in CLABSI, what we found is that story, or that process of telling a new story, came from people believing and belonging, and that largely came from creating peer learning communities. In our case, within a state or a health system, we connected the clinicians not through coercion, but from inspiration, where they would say, wow, look what Cidra's doing. They're really good. What can I learn from them? I'm as good as they are. Let me see what they're doing. And through that, we told new stories. So we said, well, what if we launched clinical communities across our health system? And it has been magical. We've published on this. It's written in the Joint Commission Journal. We're happy to get you these references. We now have about 45 of these. Some are organized by geographic area, like the PACUs or the ICUs or the emergency departments. Some are organized around topic, like cleaning, sterilization, and disinfection, or blood management. Some are service line, joint replacement, congestive heart failure. They all are co-led by an academic and a community clinician. We did that intentionally because we wanted to live our principles of humility and respect. And in our place, there's tension between the academic clinicians and the community clinicians. Many of our academic clinicians initially said, I don't need a community co-lead. I'm the world's expert in something. And we said, that's great, but you won't lead this community then, because we know change progresses at the speed of trust. And we need to do things with rather than to our colleagues. So you might be brilliant, but you will fail in driving value if you don't have this humble attitude and co-led by a community partner. And so all of them are led by that. They're charged with achieving our purpose and living our principles, but what measure they focus on, the community decides. We support them through my institute, the Armstrong Institute, with project management tools, with analytics, and with improvement science, but they work on what they want. We also, which is really the economic engine, partnered with our supply chain colleagues in finance. As you all probably know, across the globe, we in healthcare are really underdeveloped in our supply chain management, and it's a great opportunity for low-hanging fruit. Hopkins created a supply chain company and was working on it, but as you probably know, in supply chain, about 15% of the savings are negotiating better prices. 85% are what the doctors principally or the clinicians use, the clinical practice. But the finance people have very limited ability to influence the doctors. The doctors generally don't want to hear from them. So we partnered with finance, and I said, okay, sat down with the CFO and said, I'll bring these clinical communities to work on supply chain. It's in our purpose statement of driving out waste, as long as you agree to 2 principles. Number 1, that their choice will be maintained, that it'll be maintained fully aware of what the opportunities on the table, but I will not force them to use a certain statement because I'll break trust and I won't be able to influence them again. Second is they need to get a piece of the savings, not in their pocket, but to support the analytics and the project management work of these clinical communities, to support registries. And it has been just a wild, wild success. Just to give you an example, I think this year now we're up to over $40 million in savings to drive out supply chain costs. There's probably been, a couple $1 million investments in supporting this project management and supporting the Armstrong Institute, but it's, probably a 20 to 30 to 1 return on investment. Here's one example of reduction in blood cell use. We know it's one of the most overused and risky therapies. It's been difficult to get it. Clinicians led this. We gave them data about physician prescribing practices showing what their hemoglobin threshold is, down significantly. But the magic comes from connecting these clinical communities. So, for example, we had a hip and knee replacement community, and our orthopedic surgeons weren't aware that they didn't need to transfuse at such a high level. They were still transfusing at a hemoglobin of 10. And so without coercion, we simply connected those two leads, the transfusion clinical community lead with the hip and knee replacement. As you can see, literally overnight, they stopped transfusing their patients, right? It wasn't forced upon them, but it happened through this changing norms and telling a new story. They also agreed on vendors. We drove off $2,000 per case in our hip replacement. They also reduced their infection rates and length of stay. Our spine clinical community created a best practice pathway, and again, that included some supply chain efforts and took $3 million off our supply chain, as well as significant reductions in length of stay, especially for those patients who are on a pathway. Our colorectal surgery, using this our local CUS program and enhanced recovery, started telling a story that when you operate on the colon, you get infections. We, through believing and belonging, told a news story. Our infection rates are down now 4%, but more importantly, they've improved patient experience. We measure it using this survey called HCAHPS in the U.S. So I know some other countries use a version of this tool. Significant improvement in patient experience, reduction in length of stay, reduction in cost. Now, I should say in these communities, anywhere we deliver the service is invited to participate in our health system. So if it's a hospital-based thing, all 6 of our hospitals, every local group has what we call a CUSP team. That is a comprehensive unit-based safety program. That local group that works on the improvement, but we connect them in these communities. Our Armstrong Institute coordinates those connections. Another great example of sharing amongst our communities. The general surgeons aren't the only ones who operate on the bowel. Our GYN oncology surgeons do, but those 2 surgeons never talk. So we connected them to say, hey, your infection rates are a lot higher than the general surgeons. Go find out what you're doing differently. And sure enough, again, not through coercion, they saw they were doing a number of different things, implemented it, and have significant reductions. Now, I don't want to leave the impression that this is all Pollyanna-ish. It definitely works by inspiration, but we also have accountability. And what I mean by that, the shared accountability, is much like on finance, if you miss your budget, there's escalating oversight for the longer time you are missing your budget. And you all know that you miss it by 1 month, you may meet your local manager or division director. 2 months, it's going to get escalated. 3 months, you're at a higher level. 4 months, you're at the board, or you may be at a minister's level, but there's someone's watching. We haven't defined those parameters in healthcare. So what we did is we defined an explicit accountability model that says if you miss your mark by 1 month or 1 reporting period, the local CEO and local leader needs to look at it. 2 months, the local board member needs to sign off that they approve the plan. 3 months, it goes to our Johns Hopkins Medicine Quality Committee, and we coordinate through the Armstrong Institute a peer review. That is, we go in and try to understand where the defect is in that shared accountability. Is it the leader didn't give them resources? Is it the measurement's not good? Is it the local leaders aren't engaged? And then we report that finding transparently back to our board. Here's an example. In our pediatric ICU, we had a blip. In the past, that would have gone unnoticed, but they clicked to pass the 2 reporting periods. We went in and we audited, and what we found was, like often in healthcare, our understanding of accountability is highly varied. For example, in this case, the pediatric ICU sits in the Department of Pediatrics under a chair of pediatrics. The doctors are in the Department of Anesthesiology under a different department director. And when I met with the department director, or both department directors, the Department of Pediatrics said, the PICU is in my department, I'm accountable. And I said, that's great, I'm glad you're accountable. Tell me behaviorally, what does that mean? Do you ever meet with the doctors and review these rates and have them write up a plan to improve? Well, no, I don't do that, Peter. The doctors are in anesthesia, but I'm accountable for them, right? And it was just this misunderstanding, especially among our clinicians, I think, of what does accountability really mean and how do you practice it? I mentioned earlier about how we share this management discussion and analysis tool. I forgot to mention, though, we also add what did you learn at every level of the sharing as we cascade up, and what are you willing to share, or what do you think you should share with other entities and each other? Now, I want to spend a few minutes on that last part of the story about safety based on the heroism of our clinicians rather than the design of safe systems. Because if you ask me where are we going to get the most improvements in safety and productivity, it's going to be in this system engineering approach. Some of you were at the WISH when we talked about it last year. You see, in every other industry, the investments in technology have paid off wildly in better safety, in better productivity. Not so in healthcare. Despite spending enormously, there's very little data that technology has improved safety, and there's sufficient data that productivity has been negative, not positive. And if you look at, we built a brand new hospital recently, and the outside is like artwork, but the inside is probably more dangerous than it was 30 years ago, not less dangerous, not because we didn't buy the best, but the best is none of these devices talk to each other. And we're packing our hospitals or our clinics more and more full of technology, or in this case now our patient homes, and none of them talk to each other. And so our nurses now answer a false alarm every 90 seconds. Every 90 seconds. You wonder about why productivity is flat and why we introduce risks. We have nurses still, despite spending heavily on an EMR or infusion pumps, calculating heparin doses, doing the math manually. And most nurses, or many nurses, say they're not particularly good at math. We have heroically nurses making paper protractors to look at the angle of the bed to prevent ventilator-associated pneumonia. All the while, my college-age son looks at us and says, "You've got to be kidding me, Dad. There's a $2 sensor you can put to change that." So we, through a project called Emerge, went to change that. We started to say, well, if we want to work on not one harm, but all harms, what might that look like? And the math quickly gets scary. You see, we started with just 7 harms you can see listed here. There's probably a dozen or 20. But every harm has a checklist of 5 or 10 items that we should be doing to prevent it. And every one of those items might need to be done 3 or 4 or 5 times a day. So you add it up, and our clinicians would be expected to do 150 things every day to prevent these harms. No wonder why they occur, and there is not a single EMR that gives any visual display if we did these life-saving things. Not one, despite in our health system spending over $1 billion for them, because they're designed to be documentation or compliance tools, not safety tools. So without boring you, we partner with some engineerings. We built a way to get data out of the EMR, no easy feat, and to ingest a variety of sensor data and then display it on a tablet for doctors and patients. So now when I make rounds, this is live here and at UCSF, I could see every patient, and if there's a check next to their name or a red box, it means I'm missing one of those 150 things. I could then click on that, and I get the patient's view. And that patient view let me see what harms they're at risk for, and if it's gray, they're not at risk for that harm. If it's red, they're at risk and I'm missing something. If it's green, they're at risk, but they're getting all the right therapy. So instantly I could lazily focus on what I need. And then I could look on each harm, and each ring represents a checklist item. Each ring is one of those therapies that I should be providing. Now, interestingly, this clock display emerged from doing usability testing with our nurses and doctors, who all said, why on earth is every EMR displayed like an Excel spreadsheet? My brain doesn't think like that. My brain thinks like a clock. What do I need to do at 9 o'clock and 10 o'clock, and did I miss something? So we made a display focusing on this. We also have a patient portal that displays what the equipment is, just like a hotel does, about what's in your room. It has this brilliant menu of allowing patients to say what therapies they want to participate in with their loved ones and to schedule them. So, hey, I'd like to help with shaving or a bath or ambulation, and I'll be back at 3 o'clock. Can we make sure you wait to do it then? This is a whole different way of patient-centered care. And ideas of transparency, we did this as a research project. Microsoft now has formed a partnership with Johns Hopkins to begin to build this out, to make a product, to make it available. But as we close, I'd ask you to think, have you in your healthcare system declared a purpose and key principles? Do you have a performance system that includes governance and leadership, or do you still have safety as a project? Do you improve through inspiration or through coercion? Have you created this model of shared leadership accountability where staff feel supported and you hold yourself accountable first before holding others accountable? Do staff feel that you believe that they can do it, and have you created structures for peer learning? And most importantly, do you fill your days and your patients' days with love? You see, Dr. Donabedian, I think, got it right when he was asked, what's the secret of quality? And he responded that the secret of quality is love. If you have love, you can work backwards and fix the system. And what we learned in our work with CLABSI and our work here is the science of love. Love isn't a 50-year marriage. Love is, as the psychologist Barbara Friedrichsen taught us, micro moments of positive resonance. Micro moments of positive resonance. I feel warm towards you, and you feel warm towards me, and we connect. So it's you as a leader going to that unit leader and telling them you believe they can get their harm rates down. It's you putting your arm around a colleague who just made a mistake and consoling them. It's putting a hand on a scared patient and listening to them. It's looking at the environmental services worker or the house care worker, and when you walk by them, telling them how clean the floor looks and celebrating the work and their contribution to reducing infections. It's smiling at a homeless person and infusing some self-worth and some self-dignity into them. And what we saw is it's these micro moments that lead us to telling new stories that we could improve it. So at a higher level, let's ask ourselves, what are the stories that you're telling your patients and your team about? Is it possible to eliminate all harms? Because at the end of the day, if you don't create a mechanism where your staff feel you believe that they can do it, and subtle cues could derail that. Making excuses why you have low patient satisfaction or engagement scores essentially tells a story that you don't believe in your staff. Have you created this fractal structure where they belong, where they can get peer learning and you can still have accountability? But mostly, have you created these micro moments of positive receptivity where people connect and they feel love? So I'd ask you to sometime today complete your I will statement, and maybe on the question period you can share your I will statement. Because you see, Sorrel King, the mother of this little girl, wasn't just asking me, Peter, could you tell me Josie's less likely to die? She's asking every one of us. And I believe she deserves an answer. So I thank you, and I'm happy to take questions.
Great. Thank you so much, Peter. We've got our first question already from Jim Huntley. Gawande has written movingly about how some cultural change is slow and also about the resistance you encountered early in the central line drive. Culture may allow slow ideas only. Realistically, how fast can change be?
Yeah, that's a great comment. And all of this work is embedded in a culture that is either respectful and supports this. What though I think the healthcare literature and mental models gets it wrong or needs to evolve is we too often believe culture is something out there. It's something separate from us. It's something that, oh yeah, that's the noise in the system or an excuse, rather than saying we create the culture every minute of every day, these micro moments, by what we do, right? And it may be I only influence my local culture by congratulating the environmental services worker, bringing them part of my team. And so I think what we need to do is say, where can I start in my sphere of influence to create the culture that I want? If you're a leader of an organization, this performance system powerfully shapes the culture, right? Because culture is those artifacts and tools at the surface level, but that get down to those hidden assumptions about do leaders really get it, right? Are you committed? We create or break culture or trust every day. And so, the literature would say culture is a 5 or a 10-year journey, and it probably is. However, we could begin to shape that today in our spheres that we work in by the ways that we work, whether you're a clinician who says, I'm going to make sure that the patients and families are invited to join rounds, or you're the CEO who asks humbly to your clinicians, have I supported you in the work you need to do safety? So great question, and we could do a whole conference on that. It's a really rich topic.
Agreed. And just a quick follow-up question on that from David Grayson, who I believe it is almost 4 a.m. in New Zealand. So thank you, David, for joining. Was just wondering if you're happy with the pace of change at Johns Hopkins, or if you think that there's room for improvement there.
David, hey, great to hear from you. And very complicated question. No, I am not happy with the pace of change. However, as you all well know, organizations could only tolerate so much change. And the metaphor that I use, I make mistakes calibrating it, David, is of a pressure cooker. And one of the roles that I try to see is to sense what the pressure is in that pressure cooker. And if it's too low, turn up the heat to change more. But also, if it's getting boiling over, turn down the heat because you can only tolerate so much change. And what I'm feeling, at least in the U.S., but I think it's globally, is I don't know that we could change any faster, David, in part because our clinician heroism is making up for poor technology. So, for example, we're putting in EMRs, and they are clunky and clumsy, and they hurt productivity, and they really distract our clinicians. I mean, in the long run, do we need them? Yes, but they should have been much better usability tested before we put them in. And so clinicians are burdened by them. And if you look at the data on physician burnout, it's at the highest level in nurse burnout they've ever been. And in part, that's, I think, because we're using coercion rather than inspiration. I think it's in part because of these ruthless production pressures, but that are really just saying, run faster, doctor or nurse, not here's a technology that can make your work easier. And so I believe we're not anywhere near what we need to do in harm reduction or value, but I'm also mindful, because I'm a practicing intensivist also, we're going to have to get better technologies because it can't come any more out of asking our doctors and nurses to simply work harder.
Absolutely. And I know we've got a few more questions coming in, but I realize that we're also approaching time, so I may limit it to just a couple more. But this one comes in from, and I'm sorry if I mispronounce this name, Alubanmi Onia. Very sorry for mispronouncing that. But the systems in Johns Hopkins are very advanced and established. But what is the simplest way to start in a system where safety systems are still basic and cultures are long established and slow to change?
Yeah, so that's a great question. I'm glad you asked that. And, just to be clear, I presented this as a neat, tidy story, and we published it up. The reality was it was meshy. It emerged as we were going along. We kind of figured it out. And, though we are fortunate to have resources, none of this existed in 2012. I mean, there was no board committee that looked at quality across our health system. It was all created. There was no quality infrastructure within the departments. And what we used was we had a vision of, where we want to go, this fractal, aligned by a purpose, guided by principles, and we figured it out along the way, and we kind of systematically worked our way through this. So we first created the board structure to do this because that gave me the cover, and then we worked at the higher level structures of, well, what do we have in the hospitals and what do we have in home care, and assigned a leader for home care, and then they drove the home care, but aligned towards this common vision. And then we worked within hospitals and departments, and especially in our big hospitals. And now we're in the departments, and even some of the divisions are quite large. We're down at that scale. And so where do you start? Well, I think depending on where you sit in the organization, if you're a senior leader, I think having a conversation about purpose and how you want to behave and starting to do a board structure that looks at this is a great way to begin. If you're at a unit level leader, a department level leader, a clinician, perhaps picking on one harm and starting to work at that level. But I think the reality is it's going to be people like us on the phone who are going to drive this change, so we have a responsibility to begin to work towards this.
Great, and I think I'll take our last question from the audience before we wrap up. This is from Charles Payne, and I think flows well with what you were discussing earlier about the importance of cultural change. To what extent does your performance system depend on creating the conditions in which the common human values of compassion and caring can become manifest and be revealed in your staff?
Yeah, boy, great question. And, if you look at the high reliability literature or, just the quality literature or the compassion, the mindfulness literature, they may use different terms. I happen to use the term love, but what they all, include is this importance of respectful relations, and both on a unit or in your team, and then respectful interrelations, that one unit gets to know each other, and that they're galvanized by compassion, both for each other as colleagues in our days, and most importantly for the patients. So I think that is absolutely key. I wish I could say it was uniform and complete at Johns Hopkins. We are nowhere near. We still have disrespectful people. We have people less compassionate. Sometimes the production pressures and the frustrations encourages people being less compassionate. And so we've tried to make parallel efforts of bringing compassion and mindfulness both at the bedside level and at a leadership level. Let me give you one concrete thing that we've done. We make a checklist when you walk into a patient's room about what you should do, about introducing your name, and I'm happy to share with you. But one of the things to add compassion was we ask all of our employees that after you knock, to pause for 2 seconds and say the phrase, "just like me," and then fill it in. The patient is a husband, is a wife, is scared, is suffering, right? To do prompts to trigger this mind, to get people in the mindset that we share in a common humanity with our patients. Now, Could I say all of our staff are doing this? No, but I know the ones who are doing it feel that it's more joyful for them, and I think it's more rewarding for our patients. So great question, and I think we have to keep the humanistic side along with the technical and management pieces. So, thank you all for your time and attention and these great questions. It's really an honor to be able to share our journey with you.
Great, and thank you so much, Peter. Apologies to the audience members who have submitted questions that we didn't have a chance to get around to, but please feel free to follow up with me directly after at lhsn@imperial.ac.uk. And once again, thank you to all of you for joining, and especially to Peter for sharing his experiences with us today.